everyone. Thanks for being here. Great. We had Dr. ONeill fly across the pond to be here, so this is a wonderful reception. We had a dinner last night with the American Geriatrics Society Student Chapter. We met at the Kennebunk Inn, and we had a lovely time. It was just wonderful. There were 12 of us. It was just a really nice way to interact and just enjoy each other. But what I want to mention is, it was 5 years ago that we applied for the Humanism and Aging Leadership Award funding from the Gold Foundation. It's actually the Gold Foundation that we applied to for the white coat ceremony. When you apply for that grant, it is expected that they will fund you for the first year, and then you have to provide the funding every year after that. So now, the white coat ceremony is a UNECOM event. Same thing for the Humanism and Aging Leadership Award. One of the reasons why we were funded for this award is because we had a proactive part to it, that it's not just passive learning. We can select somebody who's really notable in the field, have them come in, do a lecture, give them the Humanism and Aging Leadership Award, and call it quits. But we didn't do that. We created the next part of the award, which is called the Humanism and Aging Action Award. That is a student award. You all should have at least a purple, mine's white, but yours is purple. You already got the notice about the award. This is the criteria for it for you. You need to answer the question, how would you apply what you've learned from Dr. ONeill today into your future practice? And you could do that, most students do it with a one-page, and you'll see the criteria on here, a one-page essay on that. You are welcome to do another kind of project if you are a really creative person. And especially with Dr. ONeill's humanities background, we certainly don't want to limit it to just a written piece of paper. So if you're creative, go for it. And what will happen is, it's due on February 1st. We have a panel that will go through those, and then the top 5 or 6, depending if they're pretty close, we send those to Dr. ONeill, and he makes the final determination of the rank order of your submissions. And then we will let you know by the end of February, and then we will plan a Humanism and Aging Action Award luncheon, and all the winners will present their award-winning essay or whatever it is. Is that good? Those get sent to me. It was on the original document. I don't know why it's not on this one, but those get sent to me. And I will be sending out another reminder notice when we get close to the date. We're good? Questions? Great. Okay. Turn it over to our co-presidents for the American Geriatrics Society UNECOM Student Chapter.
Hi everyone, thank you so much for coming. I'm Kelsey, I'm one of the co-presidents, as Dr. G mentioned. So I'm just going to give you a brief introduction of Dr. ONeill. So Professor Desmond ONeill is a geriatrician and stroke physician at Trinity College in Dublin, Ireland. His research centers on gerontology and the neurosciences with a strong emphasis on the humanities. He has over 300 peer-reviewed papers and chapters and is immediate past president of the European Union Geriatric Medical Society. He is the chair of the National Center for the Arts and Health. He has worked with a number of cultural agencies and institutions to develop the concepts of arts, aging, health, including the National Gallery of Ireland, the Irish Chamber Orchestra, the National Symphony Orchestra of Ireland, the Irish Film Institute, and the Institute of Art, Design and Technology in Dublin. He helped develop the first course for artists in healthcare in Ireland. He has broadcast on Lyric FM, which is Ireland's classical music station, and is an active contributor of BMJ's Medical Classics section in national media. He was awarded an All-Ireland Inspirational Life Award in 2010 for advancing the cause of older people in Ireland. Locally, Dr. ONeill is a member of the research group ITN America, based in Portland, Maine, that is addressing the transportation needs of older adults nationally. And after having dinner with Dr. ONeill last night, we realized that he is certainly all of these, but he is much more. He is amazing. He has read 1 million books, seen every movie, knows all TV shows, and also has 7 children. So he's really a fantastic guy. And I will give this award.
So we would like to present Dr. ONeill with this plaque. It says, Humanism and Aging Leadership Award is presented to Desmond ONeill, MA, MT, Professor of the Department of Medical Gerontology, Trinity College, Dublin, Adelaide and Meath Hospital, Dublin, Ireland, in appreciation of his transformational leadership and humanistic approach to the care of the whole person to promote successful aging for older adults and their caregivers. So congratulations.
Thank you very much.
Thank you.
Am I on there? Hopefully you can hear me. Well, can I say the honour is all mine, and that's not just a cliche or politeness. I had a wonderful evening yesterday with your American Geriatric Society Geriatrics Club, and with who I'd formerly known as the artist formerly known as Marilyn, and I now understand is Dr. G. And I was asking her whether she was related to Ali G, but I had to do a bit of explaining. But really, this is, we've had Dr. Geriatric over to Dublin as well, and this is a very vibrant enterprise you have here in the University of New England. The project, for example, about the students in the nursing homes is really revolutionary and has garnered the attention internationally that it deserves. And I was enormously taken with the calibre of your students yesterday. We not only had a good laugh, as we'd say in Ireland, but there's a wonderful wealth of expertise, and I think that you have a range of life experiences. And I think it's really, really important is you don't consider that some other compartment of your life, but you bring what you've brought with you into the future. It's an absolute plus and an add-on. And in talking about the humanities today, it's not going to be, I actually think sometimes doctors forget that they're actually, despite the cliche of the perhaps very focused white-coated person who hasn't an interest outside, actually international studies suggest that doctors are an extraordinarily literate and interested group of people. There's a wonderful study in The Lancet in the 1990s that showed that Norwegian doctors, despite working more hours than all other professional groups, read more outside of their profession than other groups. And I think you cannot but be engaged in the practice of medicine without being interested in the wider context. So I really feel that people must actually not make some kind of split between medicine and the humanities. And indeed, Plato would argue quite strongly in his Paideia that actually medicine is one of the fount springs of the humanities, rather than possibly the other way around. So I'll start my lecture, as I start nearly every lecture, with this wonderful piece of artwork, which I think catches beautifully the essence of the longevity dividend. If you go to the Tate Modern in London, one of the most impressive artworks to my mind is this extraordinary piece of art. It's 9 foot by 9 foot, it's vibrant, it's bright, it's stuck to you in the cracks, and it was created by somebody at the age of 83. And not only was it something created at the age of 83, but it was actually a totally new and radical style. And the likelihood is that if you have a print by Matisse in your house, it's going to be from his latest style, his découpage. Those beautiful etiolated blue and white women. It's his découpage of his later life, which are hugely what influences. And they're perhaps an extraordinarily good metaphor, and I'll keep coming back to this idea of a metaphor for the longevity dividend, what we've gained from it. Because our biggest challenge for those of us who are going to be working with older people, and unless you become a pediatrician or an obstetrician, you're going to be working with older people as your key client group, is understanding that what we've gained is enormous, yet the everyday rhetoric is one of demographic time bombs, of how will we cope, how will we manage. But interestingly enough, if you pair this painting with a picture of Matisse at the time, you catch this wonderful complexity of later life, of the fact that Matisse at this stage was quite disabled. He'd had abdominal surgery in his 70s, which went wrong, and he could no longer paint because he was used to painting standing up. It wasn't that his arms or brain or eyes weren't working. And in fact, he did this radical change, which is the sort of wonderful thing we see older people doing that we often don't measure well enough. So in these two slides, we catch the growth and the loss. And I think I would put it to you that actually an understanding of the art of longevity helps us unpick and understand the longevity dividend. So when people talk about the burden of an aging population, you say, Henri Matisse is a burden to our population. So the central message of our talk this morning, and I'm really looking forward to seeing what you come back with on this, is that aging is complexity. That there's growth and loss at all ages, and the art of the longevity dividend is twofold. It's the art of understanding the longevity dividend, and it's art which helps us to understand the longevity dividend. And don't forget, loss happens at all ages. When you are 7, there are things you could do when you were 2 that you can no longer do. You'll never learn a language the same way again, you'll never learn to walk the same way. You cannot fall as well at the age of 7 as you could without harming yourself at the age of 2. But we incorporate that in, we see that there's kind of a sense to this life stage journey. So growth and loss happen at all ages, but unfortunately the popular discourse tends to focus only on loss. So, and this complexity, one of the nice ways of encapsulating this is that we're born copies, but we die originals. And our challenge is to find ways that we can get this across to those who we are discussing about appropriate scientific care of older people. Because geriatric medicine is an extraordinarily effective form of treatment. You reduce death and disability in the acute care setting by 25%. If it was a tablet, people would be queuing around the block and everybody would have a little biro with the mark of the pharmaceutical company that could market it. But it's not a tablet. It's smart, high cognitive, high interest clinical medicine. So this, however, is the popular view of aging. It's Bono and later life, and instead of Bono being like some of the artists we're going to show later, it's this constant emphasis, and we find it throughout society, but also within medicine. So for example, this, I'm very fortunate, I have fantastic trainees come to me. So a couple of years ago in the BMJ, we did a retrospective analysis of the content of The Economist. The Economist is the most widely read weekly newspaper by members of Congress, members of Senate, parliaments around the world. And whenever The Economist talks about aging, it's always in the most negative of terms. It's apocalyptic demography, a term phrased by the gerontologists in British Columbia, which is always viewing aging as a problem rather than something positive. And indeed, look at this book here, and you might have passed this book in a bookshop before and said, that seems okay. But what's wrong with aging? I mean, what is this emphasis? And in fact, one of the key debates here is aging versus frailty. Because aging, it's neither desirable nor possible to reverse. It brings gains as well as losses. I mean, your adorable little 5-year-old, I'd love him to stay that way. Let's slather on lots of anti-aging cream and keep him that way. How bizarre would that be? But frailty is a syndrome that can be prevented, operationalized, and treated. We can't always win, but we can do better. In fact, I would put it to you, is the title of this book should be Less Frail next year. And indeed, I had an interesting platform discussion in Dublin with the author. But it spills into medicine as well. And in a very single organ-dominated medicine, very often an older person will come into the emergency room with a loss of function. They can no longer walk. And what they'll get bounced out, we can't find anything medically wrong with you. And this slide is dedicated to my father, who as a retired surgeon was sent out of the emergency room of one of the teaching hospitals in Dublin with a fractured hip. Now, a geriatrician will know that if you go from walking to not walking and can't weight bear, you've got an occult fracture until proved otherwise. And it may take a few days until it shows up, or you may need a CT scan of your hip. But this is a constant finding when older people come into the emergency room with age-related symptoms, that if a 40-year-old came in delirious, we wouldn't send her home. But an 80-year-old can come in delirious, and home they will go. So it is quite a challenge. And there's a very interesting, this is so endemic, and I'm going to give you a bit of hope at the end. But this is about 5 years ago in The Lancet, and they did a series of health and human rights. And one of the elements of the UN Charter of Human Rights is the right to the highest attainable standard of healthcare. The first 4 articles in the series were fine, and then they came up with this one here. Now, at first sight, many of you might think, well, actually, that's really good. They had aging and older people in as one of the 5 articles on human rights in healthcare. But is humane and compassionate care enough in the coronary care unit, in the OR, in the cockpit of an aeroplane? Well, actually, no. What we want is humane, competent, and compassionate care. And this is why it's so important that you have a strong geriatrics program, because you're not all going to become geriatricians, but there are competences around how to deal with multimorbidity, how to deal with frailty, and yet the mainstream 5 years ago wasn't getting it. But I have a good news story towards the end, so remember this slide. So coming to the humanities, and I think Rita Caron's, there's a danger sometimes in humanities and medicine, is that it becomes the domain of the enthusiasts, it becomes a little bit fluffy, huggy, well-meaning. So what we need is we need an intellectual framework within which we can place it, because I think the medical humanities need to be placed under the same scrutiny and microscope and same sharp and harsh debate as any other area of medicine. But Rita Caron has given this very nice idea of the simultaneous narratives going on when there's a doctor-patient relationship. It's in JAMA 2001, and there are at least 4 narratives going on. Now the easy one, the obvious one to represent is the physician and the patient. But then she talks about the physician himself, and it's the fears you have, it's the negative experiences, it's the feeling of discomfort when talking about, say, sexual health with the patient. So it's all these issues that if you don't recognize this narrative, you're going to miss things and you're going to make your own practice less comfortable. Physician and peers, and we're hugely influenced at huge amount of levels as we're sitting with the patient, because a lot of rationing goes on in healthcare, unconscious rationing. A lot we do things because we think what our peers might do, the standards are set, the quality are set by our peers. So there's always something going on in that consultation between us and our peers. But lastly, and the one where I think the important focus today is, although I think the medical humanities come into all parts, is the physician and society. Because society has a pecking order of the illnesses to which it gives huge precedence and the illnesses to which it doesn't. So we know around care of older people and mental health is there's very much a lesser focus in society, and in general we talk about the high C's of patient advocacy are cancer, cardiac and children. And for cancer, cardiac and children, society has effectively a form of open checkbook. But it was not always thus, and that's why I think it's important that we understand a little bit of the history of how policy changes, because cancer was not always thus. And in the wonderful book by Susan Sontag, Illness as Metaphor, very short, always worth reading, she had cancer in the 1980s when cancer was not as widely supported, was not as proactive, as positive, it had a degree of stigma around it. And she wrote this phrase which could well do for some of the conditions of later life, such as dementia or stroke. She talked about illness being the night side of life, a more onerous citizenship. Everyone who's born holds dual citizenship. So it's a recognition that we are all the present ill, some of us carry chronic illnesses already, and we are the future ill as well. But it's impossible to take up residence unprejudiced by the lurid metaphors with which it has been landscaped. And if the metaphors of aging are negative and nihilism and don't think about the complexity, well, then that will be reflected in the care system. And that's why I think this humanities approach to understand, because those who are in the know in geriatrics understand it's effective, it works, but we're kind of puzzled is why does the system not understand this? And a part of this may be our language as well, and I think the medical humanities can help us to understand better how to get our messages across. So here's a fabulous example, the wonderful landscape artist Hokusai, who, very radical, introduced in his 70s, quite a rascal, left illegitimate children all over Japan, but in his 70s, you know, everyone thinks of older people as conservative and timid. They are not. In fact, people take this, they begin to realize what's important in life. So Hokusai introduced the Western perspective in landscape to Japanese art when he was in his 70s. But in his postscript to 100 Views of Mount Fuji, he has this wonderful series of thoughts. That although I produced numerous designs by my 50th year, none of my work done before my 70th year is worth counting. At the age of 73, I've come to understand the true forms of animals, insects and fish, and the nature of plants and trees. Consequently, at the age of 86, I would have made more and more progress, and by 90, I would have got significantly closer to the essence of art. But the next slide is the one that encapsulates the fun and enjoyment I get out of working with older people, because we don't talk enough about their fantastic and droll sense of humour. At the age of 100, I would have reached a magnificent level, and at 110, each dot and line will be alive. I would like to ask you who live me to observe that I have not spoken without reason. So this is a theme we find again and again through the arts. And again, I always say to people, don't think of older people always in terms of, think of your own aunts, uncles, grandparents, but these fabulous metaphors. Now, this is, for those of you who may know, Louise Bourgeois, a wonderful, wonderful artist who went through fabric, textile, sculpture. This is in her mid-80s, outside the Tate Modern, this wonderful, fabulous spider. How much more, anytime somebody says to you the demographic burden, how we deal with aging, what's happening in our society, just think Louise Bourgeois' spider. Or nearer at home, go down to the Guggenheim. Frank Lloyd Wright was 73 when he began to design the Guggenheim. And indeed, he has some more radical designs after that. His workshops in Taliesin were probably one of the first environmentally, Taliesin West were the first environmentally planned buildings in the world. Quite extraordinary. And it's this radicalism which is fantastic, and the idea that people will make a fresh start. Joseph Albers, and again, I'll try and cover a range of arts, because not everyone's into visual arts, not everyone's into literature, but I think there's something for everyone, and everyone in this room has an interest in the arts somehow or other. Joseph Albers, fabulous painter, who in his 60s started this series called Homage to the Square, a wonderful exploration of colours and the interlinking between colours. But in fact, up to 60, he'd been an architect in the Bauhaus, and actually nobody ever talks about Joseph Albers, the architect. They only talk about what happened in later life. But you know, medical students are great. So they begin to shuffle in their desks at me, and they say, come on, that's great, Prof, but everybody's not an artist. Well, say, well, let's look at composers. So again, to the Geriatrics Club last night, I gave a copy of a CD of music we made of music composed after the age of 60 and sometimes into the 80s. And some of these composers composed their very greatest and most radical music into their 60s, 70s, and 80s. For it, what was really interesting, his contemporaries thought he'd lost it in his late nocturnes. Now they're his most celebrated pieces. Janáček, a Czech composer, is really interesting, only got into his stride in his 50s, and what he produced in his 70s is truly wonderful. And indeed, he's given us a fabulous, for those of you who like music and opera, he's given us a fabulous window into love in later life, because sexuality and love in later life is hugely important. And in his opera, The Cunning Little Vixen, it's about his relationship with a younger woman called Kamila Stoslova, and she's the vixen and he's the hunter in the forest. And again, it's not that music is too imprecise for words, music's too precise for words, as Mendelssohn said. And we get fabulous insights. 50 years before Gabriel Maria Marquez did his Love in the Time of Cholera, which people often talk about as perhaps, you know, the first exploration of love and sexuality in later life. Bach, Handel, Heinrich Schutz's late music, truly extraordinary. And one of the great markers of music in later life is its radicalness, its radical nature, that people seem to be able to realize that what's not important, what people think of me now, but what people think after I've gone. But enough of high art. And here's another burden on society, who continues to be at the age of 78, Gran Torino. And again, what's wonderful about it is it's a fabulous metaphor, first of all, in terms of this unbelievably productive film producer like Kurosawa in Japan, or Romer in France, but also his portrayal of change of this curmudgeonly older person, and of altruism, because there are studies showing increased altruism among older people. So again, if Joseph Albers or Frank Lloyd Wright doesn't do it for you, we'll find someone in the bag that will bring it out to you. Rock singers, pop singers. Again, this particular burden on our society made $9.5 million on this tour around Europe in 2009. Paul McCartney, Mick Jagger. I have to say I was never a Rolling Stones fan, but that was still very productive. But the students say, oh, that's fine, that's all artists. What about real life? Well then, let's look at politicians. And here's a bunch of people who came to fame in later life. So you've got Mannerheim of Finland, is my favourite. Bought out of retirement at 72, helped this small country of 3.5 million thrash the Russians twice, a country of 130 million, during the Winter War, and more importantly, to know when to sue for peace. And they withdrew from Eastern Karelia with hardly a single loss of life. Golda Meir, Reagan, Churchill. And we had a newspaper article when our last government formed. There were quite a lot of older people in the cabinet. And my response was, when the newspapers gave out about this, was, would you prefer the Winston Churchill of the disaster of Gallipoli in his younger life? Or do you want the older statesman who saved Britain during World War II? Charles de Gaulle, again, de Gaulle was a thorn in the side of the Allies during the Second World War. Everybody hated him and just irritated the pants off him. But actually, when it came to the Fifth Republic and extricating France out of Algeria, it was this older person who took them out. Now, it's very important that I don't seem to be doing a hagiography of older people. This does not mean that older people are all beautiful and kind and wonderful. What I'm saying is aging brings positive things, but you become more of what you were. And here's two examples of two extremely competent people, but also people who have to say have little to recommend them in their what they have to do with life. Pétain in France and Robert Mugabe in Zimbabwe. So again, but he's still incredibly competent. You mightn't like what he does, but he does it very competently. So they say that's fine, but real life, Prof, real life. So if you have to come down in the Hudson on a wintry day, do you want to come down with a 25-year-old JetBlue pilot? Or do you want to come down with this guy in his 60s? Life experience. And this extends to all sorts of forms in the workforce. You're very fortunate in the United States in that you have a less ageist attitude towards older workers. But there's a fabulous literature out there. And the biggest challenge to older workers, for example with information technology, is not that they're not good at information technology, but that companies don't provide them with the training in middle to later working life. And given the training, they're just as good with information technology. Older roofers, you got to say, come on, Prof, older roofers. They've got to be slower, they box more clever, they have less accidents, which is hugely important in terms of company, and they're very efficient. So there's a burgeoning occupational health literature which shows the positivity of older workers. But economics, come on, pensions, Prof, pensions. And in fact, this is, again, much of the debate about pensions is generated by tax-averse governments and pension companies who'd like to widen their margin. And again, the ARP has recognised that pension companies may take up to 1/3 of the benefit. They charge you as you put it in, and they charge you as you put it out. And in fact, Gloria Gutman and her workers and John Murphy in Chicago have been instrumental in saying, you must do the full calculation. And in fact, they are now showing a longevity dividend. That money transfers both ways. In our longitudinal study on aging, older people were 3 to 4 times more likely to make a significant financial transfer to their adult children than the other way around. Yeah. They enrich civic society, they vote more, they have a stronger belief in strong, independent institutions of society. So Murphy's calculation is 3.2 trillion a year to the US economy, added by people aging, and a longevity bonus of 1.3 million for each US citizen. People don't factor in inheritance, for example. Yet older people tend to leave things to their children. So they give during life, after life. It is the gift that keeps on giving, and yet we just don't hear it often enough. And here's a fabulous example. I'm delighted to see Kathy Freund there, because you have one of the most innovative, radical and inventive systems for alternative transportation for older people in Portland, Maine. And again, I think hopefully, I understand you're going to come and talk at a conference here in a year or two, or
No, Geriatrics conference.
Geriatrics conference, but I think but the interesting thing about it, although eventually most of us, as we grow, due to the accumulation of deficits of aging, will have to stop driving and will need alternative transportation, until we do, older drivers, despite having the highest level of morbidity, have the safest traffic record. And here's the proof from a lovely paper in the New England Journal of Medicine late last year, where they looked at people who required warning for a medical condition about driving, and then they instituted warnings. Who has the lowest amount of crashes despite the greatest amount of illnesses? The over 75-year-olds. And once the red is what happened after they gave the warnings in a routine way. The absolute lowest of any group. Now, it's not just them, but here's a beautiful paper from the pediatrics literature. If the grandparents are driving the children compared to the parents, they are less likely to use the safety features in a consistent manner. But the children have 50% chance of severe injury compared to if they're driving with their parents. So actually, not only are they safe in their own right, but they confer that safety on to their grandchildren. So it really is. And yet, the letters back to the New England Journal of Medicine, they appeared in last week's edition, there were still people talking about all the things older drivers have wrong with them. They must be more dangerous, despite the fact that the study had shown that they had the lowest crash rate. So this discourse is very challenging. So, but not only is old age the gift that keeps on giving, but the humanities as a way of explaining old age is a gift that keeps on giving. So how does it work out that despite this bunch of illnesses and disabilities, that older people still continue to be valuable, productive, provide safety on the roads? And one of the theories is a theory by Paul Baltus and Margaret Baltus. It's a theory of selection, optimization, and compensation. Now, if I put up that slide there, you know, your eyelids would begin to close. It's pre-lunch, post-lunch, you're saying, oh, yeah, another theory. But in fact, then you get this wonderful pianist, Arthur Rubinstein. And without knowing it, and before the Baltuses described this theory, Rubinstein explained selection, optimization, and compensation. And they said to Rubinstein, how come in your late 80s you're still playing and receiving wonderful plaudits? He said, well, this is what I do. He says, I now select the pieces and I take the fiendishly difficult ones off the menu. So he selects. So the older driver doesn't go out at night time and where it's icy and that sort of thing. He says, I practice much more in my 80s than when I was a young chap in my 70s, optimization. And here is the genius of later life, and it's the bit our scales often don't measure. He compensates. When there's a really fast piece that I can really not quite play as fast as I used to, I play the slow bit before it more slowly than I used to, so the fast bit appears as fast as it used to. So when you're thinking about how do older people do it, think Arthur Rubinstein, the pianist, and it just makes it so much more easy. Okay. But that being said, there is a danger of both eulogizing old age to the point that it becomes this kind of syrupy on golden pond type of thing, and also to realize that these multimorbidities do make an important difference. And in terms of driving, it's a different day's lecture. It's really important that every doctor dealing with older people knows how to assess and manage driving in terms of their multimorbidities. That's hugely important. And it's hugely important that we have smart, intelligent transportation systems like you have leading the world here in Portland, Maine with Kathy Freud's ITN. But I love this cartoon from the New Yorker. You know, the danger of over-eulogizing old age is a thing called gerontology, which is to overemphasize the positive aspects of aging at the expense of the bad things that happen. But don't forget, bad things happen at all ages of life. Loneliness peaks between 15 and 35. Between 15 and 35. People constantly, I mean, the prize-winning lecture of the Lancet 2 years ago was about loneliness among older people. It was a sentimental, horrid piece that I felt like. Where 15 to 35, think of Catcher in the Rye, think of Revolutionary Road, think how miserable life can be. People can be very lonely, very busy. But there is no doubt that loneliness does need to be tackled because you may be more housebound, you may have less outlets or ways of getting around it. But again, it is. So, can the humanities tell us about this? And the answer is, because the danger is that you only talk about the multimorbidity. And this is where the genius of the medical humanities. So, this is a wonderful painting by Edvard Munch, the Norwegian expressionist symbolist. It's himself, self-portrait with a clock in later life. And what's fabulous about this is it allows you to take several layers, but here's the two layers that I think are important. The first one is, you see a slightly miserable looking old man, thin. He was a great woman's man, and here he's now with a cast iron bedstead single bed. And you know, it looks lonely. And then on the other hand you say, wait, but I like this painting. And it's vibrant, and it's warm, and it's got colours that attract you. And you are hugely interested in Edvard Munch. You don't see Edvard Munch just as somebody who's lonely and isolated. You see, he has produced this fabulous, look at me, I'm interesting, I'm still producing. And look at the clock, no hands. What's happened to time? Time is irrelevant. And in the background are pictures of some of his conquests as a woman's man. So there's the richness there. So this is truly, truly fabulous. Goya's dark paintings. There's two wonderful rooms in the Prado, which are these murals from a cottage when Goya went through this deep depression and life was terrible. And they're absolutely horrifying pictures and often quoted as a unidirectional sort of how awful, you know, gloom and depression in later life can be. And again, this idea, you know, the autophagy, it's just, it's very harsh. But what's really interesting is, you want to see these paintings. You are energized by these paintings. They tell you things. But what's also equally interesting is that he moved on. Now, one of the most interesting gerontology papers in the last few years was Tom Gill's paper in the New Journal of Medicine, I think, which shows that it's not a constant straight line descent of decline. Is that you can measure somebody at year 1 and they're 5 out of 10, but year 2 they might be 6 out of 10. There are people pick up. So Goya moved on to doing these fabulous translucent miniatures on ivory. So it allows you not to take a caricature of failure. It allows you to say things fail in the context of a vibrant 100% human being. And then, again, Goya may not mean much to you, but I just love this. I hated the early Leonard Cohen, what we call bedsit misery of Suzanne, and I love the older one. And that lovely line in it, a broken-hearted banjo bobbing in a dark, infested sea. I mean, you know, he's telling us things about, you know, maybe it's not, no, it's not all a picnic, but it's not necessarily a picnic at any age. So, and what's wonderful about artists, older artists, is they bring us into a world that's vibrant and interesting. Now, Dr. Seuss, this is not a book for children. Dr. Seuss wrote 2 books for adults. He wrote a book in the 1940s about Lady Godiva, which Ireland, being the Catholic country it was at the time, was banned. And then he wrote this fantastic book called You're Only Old Once, a book for obsolete children. And it's his journey through the healthcare services, and really probably should be recommended reading. And it's truly, truly fantastic. And there's this wonderful descent. He starts out reading the National Geographic in the doctor's office, and he's got his dignity and his bow tie, but he's just wondering what's going to happen. And then there's this wonderful descent into mono-specialty madness. And everybody looking into everybody. And he gets increasingly disempowered and disenfranchised. Polypharmacy, the bane of our lives. So it's humorous, but it tells us the message, and it's all the better for telling us that message in a way that makes us smile. So again, you're getting lots and games, you're getting messages to doctors about what to do. And again, it's just fantastic. Optoclinics and dermoclinics, it's just wonderful. So this lifetime of experience, as I said, this should be recommended reading. But, and again, the other nice thing about art and aging is that it can bring us also, because we do need to think about the downsides. And our danger about life with dementia, for example, is I often hear people say, oh, how undignified it is for you. Now, in fact, the studies suggest that the person, without minimizing, sentimentalizing, or romanticizing dementia, his quality of life, particularly in the moderate and later stages, tends to stay quite high. That's Sufi Banerjee's work. But how do you get across the idea of this full 100% humanity when you've got barriers of language and cognition? And here's how you do it. Maurice Ravel, composing his Bolero and both of his piano concertos while he had frontotemporal dementia. Terry Pratchett, the fantasy author-writer who continues to write with a posterior cortical version of Alzheimer's disease, although I have a little unhappiness about his constant talk of assisted suicide in later stages of dementia, but that's a dialogue to be had, I think, and one we touched on last night at our dinner. And then Willem de Kooning, the great Dutch-American abstract expressionist, who painted some extraordinary paintings in his early to middle stages. There's a little kerfuffle with his agent around the middle to later stages that probably better to pass over. Indeed, may well be, in fact, one of the most stellar cases of elder, or most prominent cases of elder abuse that didn't actually get labelled as elder abuse. And this series of portraits is the sort of thing that makes me glad to be a doctor, because this series of paintings did not appear in the Burlington Arts Review, but they appeared in the Lancet. And this, because you are cut off by barriers of language and memory from telling people your narrative and your story. It can be difficult to know what's going on in the inside world of somebody with dementia. And this is the paintings of William Utermohlen, a very celebrated portrait painter in Britain. And they're his self-portraits through his journey with dementia in sequential order. And I find these quite stunning. And while it's clearly there is a loss of technical skills, there is an entirety or a wholeness. And I would want any one of these paintings, and it still tells me William Utermohlen is still strongly there and is still strongly with us. And there are really good ways of coming into this as well from other forms. So as I say, I think it's important in the medical humanities is that you, and I'll come back to this at the end, is that we don't emphasize perhaps the classics and high art. Everyone has aesthetic and cultural pursuits. What are your strengths and what are your interests and how can you marry it? So there's the wonderful book by Luria about a soldier with a head wound in the Second World War who was left with not dementia but with severe language and memory problems. And it gives you the wonderful insights that every medical student should read. For example, there's a care assistant or family member, there's a bit where he has a bowel motion comes, but all he can feel is discomfort in his stomach and he's forgotten what a bowel motion is. But then he realizes what it is, so he decides to call a nurse. But then he realizes he can't call, so he decides to gesture to the nurse, and she waves back. And he realizes he can no longer gesture in such a way that draws attention. So how many times have we passed a patient with dementia trying to tell us things like that, who has those barriers? And then he's a wonderful piece, which I keep a photocopy of it, don't tell the publishers, in my desk drawer. Because what spouses complain of more, in terms of numbers, is withdrawal or loss of a sense of relationship and love. And he's this wonderful piece at the end of leaving hospital, where my mother and sister came to see me. I was overjoyed, they were overjoyed. They kissed me and hugged me, and I realized I'd forgotten how to kiss and hug. So it's really interesting. This superb novel, I haven't gone to see the film because I can't imagine how it could be done in the film, is Mordecai Richter's last novel. And it's told from the point of view of somebody who's getting dementia. And it's really funny. He's a rascal. He said, I was the wrong type of Jew in Montreal. I didn't become a dentist and I didn't learn to play the violin. And it's truly wonderful. And there's a piece in it where a junior doctor is administering the mini medical stage examination to him, and it catches all the embarrassment and difficulty. And in fact, we've got to do better with our cognitive testing. You know, it's really, really funny. So there are, the humanities increase our repertoire, they open our windows, and what they allow us to do is to understand that people with these illnesses want to do better, and not only that, and the danger again of sentimentalizing or romanticizing, people grow with illness. And I often think this gives me resonance to this wonderful paper about people with spinal injury, showing vastly increased levels of personal growth in people with spinal injuries compared to those who haven't. Now, only people with spinal cord injuries can tell you that. You know, we have to be very careful about, again, romanticizing or sentimentalizing. Yet we do our patients wrong if we don't understand and work with them on growth that happens with illness. And lastly, in this sort of area of understanding illness and how people are very much themselves and grow and change, high art is not for everybody. And I'm hugely taken with this book by a geropsychiatrist in Florida, Mark Runnan, How We Age, where he actually does a very wonderful journey using Judaism and other precepts to work out the significance and value of people's lives. And it's truly a remarkable book. So, as I said, there's many paths into this. Okay. But the important thing is, think global, act local. What does this mean for us? Where do we stand as doctors? Do we think it's a longevity dividend, or do we think it's a burden? And how do I think about my aging? Am I welcoming my aging, or do I want the anti-aging pill? Or do I want the anti-frailty pill? Keep running, 5 fruit and veg a day. And I think it's really quite interesting. And it extends to our mission with older people. And indeed, there was a horrid blog in the DMJ yesterday talking about all we're spending on medical technology to keep people alive. And that's that bottom one there. So what is our mission? Is it an exciting job in nurturing the longevity dividend? And my favorite phrase for aging is not older people or elderly or whatever else, it's us as we age, because that's us. Or is it patching and repairing disability a kind of a noble and worthy thing? And actually in geriatrics we've got lessons to learn here. This Ignaz Nash was a Viennese doctor who came to the States and wrote, in 1909, wrote the first textbook of geriatric medicine. And I think this is just so truly fantastic, it's awesome. We realise that for all practical purposes that the lives of the aged are useless, that they're often a burden to themselves, their family and the community at large. Their appearance is generally unaesthetic, their actions objectionable, their very existence often an incubus to those in their humanity or duty must take upon themselves the care of the aged. And I really think it's really important in geriatrics. We're not doing geriatrics because it's worthy, or because it's altruistic, although with the reimbursement system in the States, it does require a degree of altruism to do geriatrics. You're doing it because it's intellectually interesting. These are rich and interesting people. It's a brilliant way of working, and with small inputs, you can do great stuff. I have to say, it's been a blast, and if I recreated, assuming I haven't been too naughty in this life and don't go back as a cockroach, I'll have more of the same. But it's still there. You might think, oh, we've moved on since then, but I love Brockelhurst's textbook, Geriatric Medicine and Gerontology, because it brings gerontology and geriatric medicine together. How on earth could I have chosen this dismal, sad, picture for the front? And you might think, well, you're being a bit picky on the iconography there, Des. But in fact, well, as I said, I'm really fortunate. I have fantastic trainees who are willing to think laterally. So in November at JAGS, we did a review of all the textbooks of geriatric medicine and gerontology in Trinity College Dublin's library. Trinity is one of 3 universities in Ireland that gets a copy by right of everything published in the British Isles, and they have a good selection as well. Only cognitive aging, of the normal cognitive aging, we want to know how do they deal with normal cognitive aging. 85% of them talked about normal cognitive aging as a loss, what you lose. Didn't talk about strategic, tactical things, didn't talk about wisdom, didn't talk about the things that make those older drivers safer. So just negative. So in fact, we've got to up our game in geriatric medicine and actually start talking about the things that grow with aging. But this is not new. Stephen Jay Gould's wonderful book, The Mismeasure of Man, shows how IQ tests, their first use was to show that black people were less intelligent than white people. And in fact, what that was about was, it was environmentally unsound in terms of their background and their education. And again, many of the tests used in neuropsychology are very loss-based. But they don't look for what you can learn. And one of the first people in this area was Salthouse, who showed that older typists type better than younger typists by slower reaction time, worse eyesight, less manual dexterity. And they had developed compensatory measures such as to look further along the line that we don't measure in our standard neuropsychology tests. And the problem for some neuropsychology is that if your only tool is a hammer, everything looks like a nail, and again, the tests are quite negative. So, are we salutogenic? And this is what we call Black Knight syndrome, if you have any Monty Python fans in the room. And this is where I think medical humanities, it's the broad range. And the Black Knight gets his arm cut off and his leg cut off and his just but his flesh wound and fights on. And it reminds me of my older people. And I'm just fascinated, his daughter comes, I see the mother, and the daughter comes in and she says, why is my mother falling? And I'm sort of sitting there thinking, she's got orthostatic hypotension, she's got vascular gait dyspraxia, she's got cognitive impairment, she's on a load of medications, she's got arthritis, a little bit of Parkinsonism. The wonder is, in terms of so I think this is what makes geriatric. And I think there's an interesting moment to start rephrasing and rethinking. And again, it's just this constant negativity about, as long as I'm not taking Ambien, as we know from this morning, anyway. Okay. And my phrase for this syndrome of constantly failing to miss the longevity dividend is the windows of Chartres Cathedral. Chartres Cathedral, France, fabulous rose window, utterly fantastic. And our challenge is to turn around the thing that the people view aging as if the people of Chartres Cathedral said, what a damn nuisance to keep cleaning those windows. So, coming towards the end now, and I'm going to have a little bit of local as well. The art of articulacy. And I got this, so there is the art of getting longevity dividend understood, and there's using the art of the longevity dividend to explain the longevity dividend. So I think we need to engage doctors, and I find that's not a problem. I think as long as we don't do the fluffy, huggy, fuzzy stuff, We say we're up there to go to peer-reviewed journals. Really, really important. You know, this is robust academic stuff. This is not some kind of little hobby. The French have a lovely word for hobby. They call it the violon d'ingres. Ingres, the great painter, used to play the violin as well, so the violon d'ingres. We need to liberate it from the straitjacket of the classics. My favourite one, Mark Twain, what a wonderful man. You know, classic is a book which everybody talks about and which nobody has read. And one of the great skeptics on medical humanity says, you know, knowledge of the Russian classics such as Dostoevsky and Tolstoy isn't much good to you at a clinic on a Monday morning unless you're dealing exclusively with elderly Russians. Personal relevance of the art form. And that's why I'm sad to see that the BMJ has stopped its medical classics rubric. But ask everyone, they've got an enthusiasm and you can make something out of it. My son is a mad soccer fan and he keeps saying, Dad, when are you going to do a column about Sir Alex Ferguson, who's at 73 is the manager of Manchester United? And they just keep slaying everyone around them. So, and again, I think actually sport, we probably haven't made enough of sport. And I think what's important is an academic partnership with the humanities. I try as much as possible, if I'm doing work in the humanities, is to do it with somebody in that area. So if it's art, to do art with an art historian, if it's music, to do it with somebody in musicology. Now, I can't always do it, but I think there is a danger of dilettantism. Now, dilettantism is quite interesting. And generally, it's considered a pejorative term. There were an interesting group of noblemen in England in the 18th century, of whom Horace Walpole said there were only two criteria needed to become one of the dilettanti. You had to have gone to Italy once, and to be drunk most of the time. There's one in every medical school. But on the other hand, the dilettanti did help with the revival of classicism in English cultural life. And quite interestingly, both Nietzsche and Adorno, the philosophers, thought that one of the key secrets of Wagner was his dilettantism, that he strayed outside of music and went into theatre and myth and other art forms. So again, the danger is excessive dilettantism. And again, but the tide is turning, and I think if I were to say, what one film would you tell people to do to understand gerontology, I would say Pixar's Magnificent Up. And if you think it's a children's movie, think again. The first 10 minutes deal with infertility, death, and lifelong disappointment. And but it's a truly, truly wonderful movie that catches that combination of tough but frail that increasingly characterizes older people in the 21st century. Really, really interesting. And the good news is that life does move on. So through the advocacy of geriatricians, 5 years later, the Lancet has started putting competence into the care of older people. And one of the most truly, people tend to think their voice doesn't matter. Their voice does matter because a lot of us have been in correspondence with the Lancet. And they're slowly coming around. So there's a great statue in Dublin of a trade union leader called Jim Larkin. And his famous phrase was, "The great appear great because we are on our knees. Arise." And I think you can make a difference and you can make a change. And this, to me, I was asked to do a review of the year's literature in gerontology and geriatric medicine. And I have to say, this is the one I finished on, is for the first time ever, a major medical journal put out there in its front cover that aging is most often framed in negative terms, questioning whether health services, welfare provision, and economic growth are sustainable. We argue that, instead of being portrayed as a problem, increased human longevity should be a cause for celebration. And indeed, as you possibly, hopefully, are aware from your public health, we now know for about 25 years is that population aging has not added to healthcare costs. It's largely technology, which is largely used by people in the late middle age rather than actually older people. But this is, to me, the most encouraging, that the first time ever that the longevity dividend has made it to frontline use of probably the highest dividend, with vying with the New England Journal of Medicine. So, our aim must be to get from, Wagner talked about a Gesamtkunstwerk, that means a total artwork, theatre, music, and everything else. Our aim must be to try and get to a Gesamtgesundheitwerk, a complete health work, with the biopsychosocial model and geriatric medicine, medical humanity, gerontology, narrative medicine, neurosciences, and arts and health. And I think it's a heady brew, and I think it's a really interesting journey. but let's keep it local. And of course, what fascinates me as a caregiver, I mean, I've always wanted to come to Portland, and so if you want to look for the longevity dividend, you don't have to go far. So here's two Winslow Homers in your Portland gallery, which were painted in the 60s. This is Ross Sterling Turner, again painted at the age of 60, a beautiful, beautiful painting. And Andrew Wyatt, I have to say, I tend to use Christina's World. Andrew Wyatt is a really interesting painting about neurological disease. Worth checking it out. But again, here's a painting from him at age 74, and he continued, but you can see, look, he had other paintings later, but again, it's a little bit jelly about that size of the reproduction. And then Kandinsky, and Kandinsky is the most magnificent, constant purification, distillation. So here he is at 63. Now again, some people might say, aren't you a bit early at 60? But again, longevity has increased. And we'll come to that in a second. And again, I think what's going to be really interesting is Lois Dodd, this extraordinarily productive Maine artist, and I'm really sorry I'm going to be missing her exhibition here. Witty, interesting painting. Here she is with her self-portrait at a window, and I think among the paintings that are going to be here, this is from the age of 90, this, and here's one, a young work at the age of 81. But maybe let's stick with UNE, and I think, you know, I'm really looking forward to getting to see your gallery this afternoon, so my apologies, this is taken from the web, but the current exhibition of Maine women artists, look at the ages of them, it's quite stunning. And they're really, from an 81-year-old. Now, this is, oh, isn't it 81, isn't it wonderful? It's not that, and actually it's quite interesting. Sometimes in debate with artists, some of them are a bit offended that I would take them out of, you know, ageism is so prevalent. They say, I don't want my longevity dividend to be, I'm Louis Le Brocchi, I'm painting at 91, stop. And I said, but you're helping everybody here, Louis, by talking about it. But look at how radical and interesting this vision is. Conservative, timid. Beverly Hallam, and again in her 60s, and Hildreth at 78. And this wonderful, wonderful piece, again, relatively young at 67, but interesting. So the last word, if an Irishman give me the lecture, has to go to an Irishman. And I love this piece from Samuel Beckett. And Samuel Beckett, he understood the treachery of language and linear thinking, and I love this. I always thought old age would be a writer's best chance. Whenever I read the late work of Goethe or W.B. Yeats, I had the impertinence to identify it. Now my memory's gone, all the old fluency's disappeared. I don't write a single sentence without saying to myself, it's a lie. So I know I was right. It's the best chance I've ever had. Thank you very much again.
Do we have time for questions? Dave, do they need to speak into the microphone, or?
No, I think
Dr.
we'll be okay.
O'Neill can just- Okay.
Speak up.
I have one. Do you know about the Maine Humanities Council's Literature Medicine Program?
I don't know.
I'll make sure
Hopefully
you
I'll find out more, yes.
do.
I mean, it is interesting. I mean, I think the literature is interesting, but the beginnings of narrative medicine, I think, actually were possibly. I love reading. I'm a voracious reader. I'm a speed reader gene, as my mother is 88, will read 2 books in a weekend. But the thing about it, we did a survey of aesthetic, culture, and leisure pursuits of students, and although medical students, and although they are way above the average of the population, actually, it would strike me that actually reading for pleasure has taken a bit of a hit. And I think the danger about literature and medicine is that it's not for everybody. So I think you need cinema, you need, you know, I think media studies, television. I mean, my teenage and adult children introduced me to the episode 1 of series 1 of Grey's Anatomy, and there's a wonderful piece in it because our relationship with Carons, us and our peers. One of the surgeons, trainees kill somebody, somebody dies under the care, and they all call him 07 after that, and he says, I should have done geriatrics. Nobody minds if somebody dies on your watch. And one of the other doctors goes back to him and says, no, surgery's matter, stay with surgery. Geriatrics is for people who don't have sex and live with their mom. So, I can tell you from my knowledge, no, it's not true. Stop there. Sorry. But anyway, but I do think But for those with an interest in literature, it's one of the most fabulous, profound ways of getting through it. But I think that we've got to keep everybody in the choral as well.
And for the students here that weren't with us for dinner last night, you're welcome to ask about medical education in Ireland or anything about Dr. O'Neill's practice, because you didn't have a chance to get any of that. So.
I'll just tell you a little bit about geriatric. One of the interesting things about traveling is if you go around the world, a cardiologist does much the same in most countries, and urologist does much the same. But geriatricians are quite different. In most of Europe, geriatricians are internists, and in the broad swathe of northwestern Europe, in many countries such as Scandinavia, Holland, England, Ireland, they're the largest group specialty of internal medicine. Their practice, however, does vary quite a bit. And Finland is probably the only country in Europe that has a strong primary care general practice track in geriatric medicine. And I actually think it's something we're missing out on as I look at the system here. And in fact, primary care and geriatric has gone off in its own track. And it's not only are they not aware that they don't know about the skills of older people, but they've got what we call an anosognosia. They don't know that they're not aware of the skills needed for older people. I don't understand condescending or patronising towards them, but there is a big issue, particularly when they're involved with the care of older people. Ireland and England and Norway is quite interesting in that we do quite a bit of acute stroke. So, for example, the night before I came here, I was on call for thrombolysis by telemedicine. So virtually all the stroke units in Ireland are run by geriatricians, acute stroke and thrombolysis. At a slight cost, I think, perhaps to, life is a zero-sum game. So we're probably not as active in nursing home medicine as we should be, but that's something we're working on at the moment. So we do a 3-year common trunk of medicine, a bit like a residency, and then you can either become a pure geriatrician in 4 years, or you can become a geriatrician internist in 5 years. And you do, in that you do 1 year of high-intensity general internal medicine, 2 years of mixed low-intensity general internal medicine, geriatric medicine, and 2 years of geriatric medicine. But it varies around Europe hugely, and I think where geriatric medicine has worked in Europe, it's because governments have said this is worth doing, and they've made sure that you're not financially incredibly at a loss for doing it. So I get the same public salary as a cardiologist gets, or a neurologist. Now again, they can earn shed loads outside if they want to use their time outside, but and that probably is, I think, a very important factor. So certainly it's something I would have written about in JAGS around the development of geriatric medicine. There needs to be, without making too much special case pleading, but the reimbursement system here is a huge challenge. Yeah.
So I think it's, it would be important for society to kind of change their views, but how do you deal with the actual patients and when they're depressed or when they're very upset about aging? I don't know how to necessarily say, oh, there's these artists and you have all these other great things you can do now, and what do you think is the best way to approach the patient?
Well, it's interesting. Most of the longitudinal studies and surveys show that actually older people generally have at least as good, if not a higher quality of life than the generations before them. Because again, there's a survivor effect. The meek and the weak die young. Generally, if I find people talking in negative ways about aging, it tends to come around 2 or 3 things that you might be able to do something about. And rather than, again, one has to be judicious in how you use these examples. I think these examples of achievement in that may actually seem like a cruel jest to somebody in that situation. But I'd be thinking about depression, I'd be thinking about social isolation and loneliness, and I'd be thinking around what we might do in those sort of areas. But in general, we always feel, the self-perception of aging. There's a thing called the Aging Perception Questionnaire, and one of the most interesting, it is hugely important that older people suffer from ageism, we now know, in 2 ways, at least 2 ways. One is all the services and things they don't get, either standard services, such as, for example, breast cancer screening in much of Europe stops at 65, when you're 7 times more likely to get breast cancer after the age of 65 and 7 times more likely to die of it. But also that you would not get gerontologically attuned services. But the second ageism is around how you yourself view aging. And there's a really interesting paper during the last year which showed that older people who have negative perceptions of aging do less well in health services. So again, we have ageism is not just for those under 65, 70, it's for those over 65 or 70. And I'm very fortunate to have a modern purpose-built unit. And sometimes a 91-year-old will come in and she'll say to me, I don't want to be with the older people. Now, actually, if you parse that through, it's quite interesting. Part of it is ageism, but part of it is their understanding of society's ageism, that if I'm going into a unit that's just for older people, maybe it won't be as up to speed or up to, you know, so it might actually be ye grauer, ye schlauer, you know, they're getting grayer, you're getting wiser. So again, there's an interesting dialogue around that. And you know, the dream in 100 years' time is that every physician, internist, surgeon is gerontologically attuned and has a modicum of geriatrics experience and then knows how to work with geriatricians. But we're a long way off. But coming back to your original, few enough people. The other thing, and I think which is quite interesting, and it is an adaptation change, is your peers dying. I think your peers dying is a hard part of aging that people may need to address. This feeling of, but other things come in their place often. You know, it's, yeah.
Anybody?
Yeah. Go ahead.
Do you ever see ageism within the medical profession, like doctors, prejudice against older doctors?
Yeah, I don't think that's what I didn't know. That's an interesting concept. I'll just have to think about that. Not hugely, no, not hugely. But again, I have the privilege of working generally in a university teaching hospital. It's quite competitive. So, you know, at Grand Rounds, everybody wants to be the one saying, well, I know about exon 33 on branch, you know, 5 for chromosome. But no, that's an interesting point. But I think there's an important difference between Europe and Ireland and the US is that I'm the last wave of people who have to retire at 65. After me, people will be able to continue working. So people tend to stop working at 65, whereas I know here people do continue working. And I have to say, I think it's a terrible loss in all sense of the word. And actually, my colleagues have been appointed after me. It's discretionary whether they retire at 65. So again, I may not have the same type of exposure as you may have. I mean, can I ask here, do you get a sense that there might be a little bit of that? You don't want to risk your career. French firm teachers looking for doctors? Any sense?
Yeah, just a quick comment on that. I think generally we view older physicians as just having seen more patients. And I think we're acutely aware right now that the more we see, the more we know.
Yep.
And so I think they're highly respected for what they do.
I'll begin.
To counter that though, in some cases they can pull in a little bit more money in other cases, and so if there's a budget concern at a hospital, I know a family friend who's a physician has recently lost his job at the hospital because they want one of these people a little bit younger because they'll be able to be a little bit cheaper. So.
Yeah, it's interesting. Yeah. No, it's interesting. I mean, and it's interesting. One of the things that doesn't come up a lot, we've just got a paper, Exempt in Age and Aging, which is about dementia in the liberal professions. And it's quite interesting because in our practice I see architects, engineers, doctors who have dementia. And it's interesting how it's a hugely interesting debate because by and large I find the doctors tend to be quite prudent about it. I know I haven't had one in frontotemporal dementia who mightn't be prudent. They tend to be prudent. But what's interesting too is the discussion about should a doctor with mild dementia who probably is quite okay, you know, because we're raising the bar all the time or make me more sensitive. And indeed, Barbara Kingsolver's book, Animal Dreams, has a lovely character in it who's a family doctor with a mild dementia. But it's interesting because people say, well, of course, he should tell his patients that he's got dementia, or he or she. And I'm saying, well, does he tell them that he's got a substance abuse problem? Does he tell them, you know, does he tell them that he's depressed or bipolar? Which could equally affect his performance. So, and again, it raises some of the issues around society's values and judgment around dementia. Those people wouldn't dream of saying that to me about substance abuse, and wouldn't dream of saying it to me about mental health, but they'll say it about dementia. It was sparked by an architect I had who, all through his life, he built houses that were watertight, but the last house was not watertight. Yeah.
I'm interested in hearing your thoughts on, it's sort of similar to the first question. It seems like a fair amount of anxiety at the end of life, particularly with elderly people, is the fear of death and the anxiety surrounding the uncertainty of the future and what's going to happen after they die. For someone with, you know, strong religious faith, that may be easier than someone with, say, no religious or faith-based outlet. How would you approach a patient who comes to you and says, I'm you know, scared to death of dying, basically?
it's a good point, and it's always quite difficult in the abstract. And I'm not sure if anybody has actually, and I'm in practice since qualifying in '83. I'm not sure I mean, I'll be aware of people who are finding it much more difficult than others. But I was just discussing it last night. One of the most interesting writers in this area is Harvey Chuchinoff. He's in Winnipeg, an extraordinary palliative care physician who is very different and talks about, he's very useful in talking about spirituality, the generic issue of spirituality, because I think the thing about, I think we're all spiritual, agnostic, atheist or religious, we're all spiritual. And one of our challenges as healthcare practitioners is how do we tease it out without bringing necessarily religion into it. And that's a real challenge. But I find it slightly different. I suppose my mother's very stoic and humorous. She's in her bedroom at home. She's 88, she's got spinal stenosis. She's put a little DNR label over herself. I haven't had that sort of articulation, and maybe I wasn't hearing it. So I find it hard to answer, except to say that I haven't really come across it. And I find again, I deal with stroke, and I do some general take, and then I hand back the under 65s to the general physicians. And there's no doubt in my mind is that the older people seem to accommodate and adapt better to the end than the younger people. Yeah.
Any other questions? It's your opportunity. He's going back to Ireland. It's going to be hard to talk to him there. One piece of advice for them that you can share?
Gosh, I'm not
No
sure.
pressure.
No pressure. I think that nothing is wasted. Nothing is wasted. And as people always said to me, it was the jobs you didn't get that mattered. So when I was going for my higher trainee job, I went for Oxford and I didn't get it, and then I got Bristol, which was wonderful. And as it turned out, Oxford was a dog of a job. It would have been a retrograde step. So, the reverses of life, but I also think I was huge. I can't say it. I'm not just soft-soaping you. I was hugely impressed by the life experiences, and for those who had come earlier, don't be put off by that and learn from your colleagues. But I think what you learned before you did medicine is just as important. And I was hearing of, for example, one of the things in geriatrics, as you can clearly see, we haven't always got our message across to others in geriatric medicine. And I think our danger is that we think we have the knowledge, and we've been saying it from the mountain for 50 years, and it hasn't got through. So maybe actually we weren't saying it in the right way. So psychology, marketing, business, all those sort of things. We need to take stock of how we're putting our message across. So nothing is wasted. And I suppose the last thing is, for all that I might say about reading, as I said, get into the habit of writing things down. One of the best experiences I had, we ran a conference on medical humanities and aging in Dublin last year, and there was a wonderful speaker came from Rita Caron's group, and she did this really fantastic exercise, because I think, a bit like the great appear great because we are on our knees, people are terrified of writing. So she said, one sheet of paper, and I want you to write for 3 minutes, just 3 minutes, on a scar in your life. So we all write our little piece. And it was truly illuminating and revelatory to me, is if you take a small piece of what people can do. The other thing I learned from it is, boys only have physical scars. A girl, because she asked us to exchange with your neighbour. At dinner afterwards, all the boys ever had were physical scars. So I think nothing is wasted, and get into the habit of writing down. Yeah.
Well, thank you very much.
Thank you.